Hello, everyone, and welcome back to the UB Medicine podcast. I'm Dr. Allison Brashear, the Dean of the Jacobs School of Medicine and Biomedical Sciences and Vice President for Health Sciences here at the University at Buffalo. Today, we're focusing on part of medicine where progress is measured not only by discoveries and data, but in childhoods preserved, futures restored, and families supported through some of the most difficult moments they will ever face. For decades, a pediatric cancer diagnosis was almost uniformly devastating. Locally, that story has been shaped by long-standing collaboration. For also decades, UB physicians have worked alongside colleagues at the Roswell Park Comprehensive Cancer Center and recently the Golisano Children's Hospital, really focusing on childhood cancers. And in Western New York, this program really leads to leading-edge research, highly specialized care, and deeply family-centered support close to home. Today, because of advances in research and collaboration and care, survival rates are dramatically higher. Yet, pediatric oncology remains one of the most complex and demanding fields in medicine, where innovation must continue, long-term outcomes really matter, and the care is extended way beyond the walls of the hospital. So this episode is to kind of walk through the rewriting of pediatric cancer, to talk about the programs we have here at UB. And I just want you to join me now to welcome two leaders at the Jacobs School whose work really spans the full continuum from pediatric cancer care, laboratory discovery, clinical trials, and from diagnosis through long-term survivorship. Dr. Kara Kelly is a professor and the division chief of hematology oncology in the Department of Pediatrics at the Jacobs School of Medicine and Biomedical Sciences, and she is a nationally recognized leader in pediatric hematology and oncology. She is the chair of the Department of Pediatric Oncology and the Waldemar J. Kaminsky Endowed Chair of Pediatric at Roswell Park Comprehensive Cancer Center, where she cares for children and families and leads one of the country's most comprehensive cancer centers in partnership with Roswell Park, Golisano Children's Hospital, and the University at Buffalo, the Jacobs School. Throughout her career, Dr. Kelly has walked with children and families through every stage of cancer journey, from diagnosis to treatment to survivorship, really bringing together research, clinical expertise, and deeply passionate care. Dr. Andrew Rogers is a bit newer to Buffalo. He's an assistant professor of pediatrics and also the Department of Medicine. Is that right? Okay, and in the Jacobs School. And he's also a pediatric cancer researcher who focuses work on improving how children and adolescents experience cancer and its treatment. He also holds an adjunct research appointment at Roswell Park, and his work is deeply integrated in the care of young patients and their families. Dr. Rogers' research centers on pain, symptom management, and quality of life. And by studying physical and emotional challenges children face during treatment, and then he carries those insights back to the clinic, his work really helps ensure that progress in cancer therapy is matched by progress in how children heal, function, and thrive during treatment, and most importantly in all of this, how they move into survivorship. Karen, Andrew, thank you for joining me here today. So first of all, to really appreciate how pediatric cancer care is headed, it helps to remember how far we have come. So I'll start with Kara. When you look back over the last few decades, what advances have most dramatically changed outcomes for children with cancer?
I have to say childhood cancer is a field where there has just been so much dramatic progress, from back in the 1950s and 60s when very few children were cured to now 80% of all children with cancer are cured. And some diseases, particularly the ones that I focus on, acute lymphoblastic leukemia, Hodgkin lymphoma, the survival rates are well over 95%. What's really helped to enable that has been collaborative clinical trials. In fact, many people may not realize that some of the initial leaders in these clinical trials were right here in Buffalo. They were part of the first group of people to come together and say, childhood cancer is rare. We can't do it alone. We've got to come together. And that resulted in National Institute of Health supported research consortium, which have really driven those tremendous response rates. And, it's just amazing now to be able to have such high cure rates.
That's incredible. So, because how do families experience these advances in day to day? Because you mentioned diagnosis of ALL in the past was devastating.
Yes.
How do we share those advances with patients? So when you make that diagnosis now, it's not the same.
No, and I think that the way that we approach it is that if there is a clinical trial available, that's what we offer as the care, and that's how we're able to offer the most cutting edge diagnostic studies, the latest advances in treatment through participation in these clinical trials. And I think, fortunately, most families recognize that and do agree to be on these treatment trials. I was just in clinic this morning and seeing some of my patients. I have a little boy with a very high risk form of acute lymphoblastic leukemia. In the past, he would have been treated with very intensive chemotherapy, and with that have, a prognosis of about 60%. But we have a clinical trial now that offers immunotherapy with a class of drug called a bispecific antibody, as well as more targeted drugs that work specifically on the gene mutations that we've identified through our diagnostic testing. And with that, he's able to tolerate the therapy much better. And, the prognosis is much, much better than it was in the past with conventional chemotherapy. So lots of hope, lots of advances, lots that we're offering to patients, right in our clinic.
The clinical trials that you spoke of, those things are available because we're in an academic setting here, in a research setting. Those are not clinical trials that you get just from you really have to be in a place like UB.
Right, absolutely. Childhood, as you said in your, initial remarks, it's very complex. These therapies, while effective, there's, potential for side effects, and you really need the expertise that you get at an academic environment in order to maximize, the response to cure rate and minimize both the short-term and the long-term side effects of therapy. So really, patients should all be treated in academic centers.
So Andrew, you're a bit newer to Buffalo, and your work is about survivorship. Help me understand how you would take perhaps this patient and then partner with our clinicians.
Yeah. I think one of the things that comes with these really high survival rates is that a lot of these kids, adolescents, young adults end up living with some of the complications of having cancer or its treatments for many, many years. Some of those things, particularly the things that I focus on, are things like pain, fatigue, sort of other sort of physical symptoms that are really, really difficult to treat. And so when we think about cancer care and survivorship care, we don't really think about it stopping when the cancer is gone. We think about extending it really for the life of the patient, because these are things that they will deal with for a long time.
Right. And even if they've been cured, they have these residual pieces, let alone the experience of not having a normal childhood. When you can't call the childhood normal when you're getting your chemotherapy and radiation or whatever.
And I think that's what makes survivorship care so complicated, because it's not just about treating and managing the symptoms, but it's about all these other developmental milestones that happen differently for kids, adolescents, young adults who had a cancer diagnosis and had to pause their life for a certain amount of time.
Right. So, Kara, how do we treat the whole patient? Because you mentioned about the drugs and this particular individual, but you have a team around you.
That's right. Right. It is, standard of care to bring in a number of different experts into the care of every child, and not only the child, but the whole family. So patients are seen by the physicians, psychologists, social workers. We have child life specialists who are experts in the developmental stage of the child that help them to adapt to the illness and the treatment. We have nutritionists, exercise, physical therapists. So all of it is about, maintaining the function as well as really the whole person, the emotional support. I think, as you mentioned, there's, really not much worse for a parent in hearing your child has cancer. And so right from day one, we're focused on supporting all of them together.
And so you mentioned things like emotional support, well-being is so important. Tell me a little bit about the role of nutrition in supporting cancer patients.
Yeah, I can. That's actually been an area where some of my research has been focused on. And I think, there are certain situations where children are at risk for weight loss and undernutrition, but increasingly so, especially in our survivors of childhood cancer, we're seeing high rates of obesity and really abnormal weight gain that combined with the late effects of their cancer treatment can put them at high risk for complications like metabolic syndrome, lipid disorders, can lead to premature heart disease, diabetes. So we actually have a study open right now that is an intensive nutritional counseling intervention where families meet weekly over Zoom to get more tailored nutritional counseling as a means of trying to kind of shift them towards more healthy dietary patterns and with the hope of being able to reduce that abnormal weight gain. I think increasingly we're recognizing, as Dr. Rogers said, that it's not just about, that short term, the treatment, but looking at the patients across the whole, time frame.
So let's switch back to Dr. Rogers. Let's talk a little bit about pain and your work. How do you help children with pain?
Yeah, so pain in childhood cancer patients or survivors is really complicated, and I think that we're really starting to just understand what pain is in this population, and particularly why it persists for some and not for others. And I think that those who do have pain into survivorship are, very, very challenging to treat. And there's really not much that we know about what works. And so taking some of my sort of work from the non-cancer space, you really think about behavioral self-management and knowing that, childhood cancer survivors, adolescents experience sort of a different set of circumstances that might impact why their pain persists, for how long, how severe, how impairing it is. And so I think this is really where my work is starting, is to, understand what some of these mechanisms might be that are maintaining this. And I'm currently working on some work with Dr. Kelly and Dr. Ajay Gupta, really trying to understand, are there targets for these sort of behavioral self-management interventions that could really help these adolescent young adult cancer survivors?
Is there any work going on in psychological support for those patients, particularly after they've, with pain and management after they come out of their acute cancer treatment? Because I would imagine in children, that's a whole different piece.
Yeah, there is psychological support. I think one of the sort of pros about, Dr. Kelly's program is, there's a survivorship program for, childhood cancer survivors, adolescents, that really offers a lot of these things, but pain specific support, I think, is an area where we're lacking. And I think a lot of my work, even with providers, kind of identified this as a major gap of, we know our patients have pain, but where do we send them? How do we get them support? And I think that that's, where a lot of my work has been focused.
Could you both talk a little bit more about clinical trials? So, I've always been just deeply committed to making sure that people have access to clinical trials. And Kara, to your point earlier about, academic medical centers like us offer something different and greatly partner with our individuals in the community across the country and particularly in the region. But clinical trials is such an important piece because that's the way we bring, as you said, emerging cutting edge new therapies to the patients in a much more timely manner. It takes years sometimes, sadly, to get drugs approved by the FDA. So speak to me about clinical trials and how you enroll children in clinical trials, which must be even more complicated.
Yes, I think that, as I said before, there's really a culture of clinical trial participation in pediatric cancer. Pediatric cancer is rare across the United States. There's only about 16,000 children diagnosed with cancer per year. And so if you look at each individual center, they only, treat a relatively limited number. So we really, since the first cooperative groups were formed in the 1960s, that's really been the standard. As you work together, you develop these clinical trials. I think what's people should know about here at Buffalo is not only do we offer clinical trials, but many of our faculty members are actually the experts that are designing these clinical trials, that
including
are
yourself.
I'm
Last I
also-
remember, you've been published in New England Journal of Medicine.
But, even besides me, there, several of my faculty are involved in developing clinical trials in, some very aggressive, hard to treat cancers like neuroblastoma or very high grade brain tumors, and really working to bring innovation to these different groups of patients that are in need of new therapies. Right now it is such an exciting time in cancer therapy. We have, with more of from DNA sequencing work and other discoveries in the laboratory, we are now rapidly translating these into clinical trials so that we can really determine how best to offer these therapies to our patients. And I think also importantly, as a pediatric oncologist, what I'm excited to see is more collaboration with our adult colleagues, so that instead of in the past, we would do a trial first in adults, and then we'd have to wait on average 6 years before results would come out from clinical trials in children. We're now, for some of the more common cancers that occur in that adolescent young adult group, we're doing trials together, and that's really rapidly accelerating access to new treatments for children, which is very exciting.
That's terrific. What are the top couple cancers in children?
Sure. So the most common cancer is leukemia, accounts for about a third of all cancers we see, and also similar numbers, brain tumors. So those are kind of about 2/3 of all cancers. And then, the thing, and then after that, there's lots of different types of cancers that occur. My work is, in leukemia and lymphoma. Lymphoma is about 10% of cancers. And then we have a whole bunch of different solid tumors, bone tumors, neuroblastoma, kidney tumors.
All ones that many have made dramatic advances in the treatments.
Right. Yeah. Just again, with all of these new immunotherapies, targeted drugs, it used to be maybe 15, 20 years ago, there were only about 5 to 10 drugs specifically approved by the FDA for pediatric cancer, and kind of lost count, but I think it's over 50 to 60 in that last decade and a half. Just again, so much advancement. And so it's exciting to have more options.
That's terrific. So Andrew, you just came here a bit ago. Tell us about what drew you to Buffalo and what was special about this opportunity.
Yeah, I think that coming here, moved my family here across the country from Seattle. And, I think that one of the things I was really looking for is an opportunity to really have this collaborative, integrated care that doesn't stop at the end of cancer, really, that is from diagnosis all the way through survivorship. And I met Dr. Kelly right at the beginning of my recruitment journey. And I worked with Dr. Jeff Lackner in the Division of Behavioral Medicine. Really found that there was an opportunity to explore this intersection of pain, cancer that really nobody was doing here, and is actually a very, very small group of us around the country that studies specifically chronic pain in cancer patients. I really found that there was sort of rich opportunity at the intersection of UB and Roswell Park, and it has exceeded expectations thus far. And we've started to really figure out how do we enroll pediatric cancer survivors in studies, which is a challenge and really a rewarding opportunity. And so it's been really great.
Well, we're glad you're here. I would be remiss if I didn't ask about precision medicine. I think you mentioned some whole genome sequencing, et cetera. So how do you think precision medicine is going to pave the way? And of course, I would be also remiss if I didn't mention the 2 letters AI. How is that going to help us find new treatments and get things to kids sooner?
Yeah, from the precision medicine now, we're getting close to, we're sequencing, doing these DNA sequencing tests on almost every cancer type that we see, any new patient coming in. And in many subtypes, brain tumors, leukemia, information from that is being directly used to match patients to the most appropriate treatment. So it's standard of care now. It's something, but again, that you only get at an academic center. That's again stresses the importance of that. We're also now able to identify increasingly so children that have a germline predisposition to cancer. And so with that information, we're providing genetic counseling, testing of their family members, putting together personalized screening plans. In the past, we never realized that they were there, but with this precision medicine information, we can truly act on it to provide, again, that more family-based recommendations.
Now, how would any child know to be screened for a germline?
Sure.
That must be because they had some family history trigger or
sometimes
something?
Sometimes it's family history. Sometimes it's certain types of cancers where there's a higher risk. But because we're increasingly doing sequencing of the tumor, you can get some clues from the results out there that there may be an underlying. For example, I saw a patient today who had a CHEK mutation seen on his leukemia screen, which suggests that this may be a cancer predisposition syndrome. So I just today sent some, germline testing on it, and if it confirms our suspicion, we will then bring the whole family in for counseling and determination of who needs testing and whether any other studies are needed. So this is now, what we're doing routinely. We have a specialized clinic where we're seeing patients each month in order to provide that service.
Wonderful. Well, I have one final question for both of you. What is one idea that you hope listeners take away from the future of science and health in Western New York? And Andrew, I'll start with you, and then we'll close with Kara.
Yeah, I think that hope is a big thing, as really what we've all been talking about is that it's not, it doesn't mean what it used to mean when you have a pediatric cancer diagnosis. And I think that we're sort of really at the edge of innovation and really moving forward, not just for cancer care, but survivorship care and symptom care. And I think that there's a lot that is being done really with this idea of improving the lives of cancer survivors. And I'm really hopeful that we'll get there. And I'm excited to see where we'll go.
Great. And Kara, what's your one big takeaway about the future?
I think it's very bright. We have just advances in the laboratory that are being translated into clinical practice through clinical trials has just changing the way that we're approaching pediatric cancer treatment every day. There are so many with immunotherapy, targeted drugs. We're able to not only achieve higher cure rates, but also reduce the side effects of the treatment, which we will translate to even improve survivorship in the long term. It's just an incredibly exciting time.
It's very inspiring. Karen, Andrew, I want to thank you both. This has been a very heartfelt conversation, and one that I think we all will be inspired about. It's a chance to learn about discovery, compassionate care, survivorship in children, and one conversation that I think is important for people to hear, that there is absolute hope and absolute advancement, and we are every day putting the results of science to work, and that is improving the health of our patients, particularly the smallest and the most at risk. Thank you so much. I'm Dr. Allison Brashear, and this has been the UB Medicine Podcast. I want to thank all of you for listening, and we look forward to continuing the conversation about innovation, care, and hope here in Western New York and beyond.